Good morning, everybody. It's a great honor for Helwan University and Faculty of Medicine in particular to have such great scientific gathering of international guest speakers from Germany, Martin Luther University Hospital, Halle, and Japan, National Institute of Infectious Disease, and Kyushu University. And our national expertise in both therapeutic medical issues and educational aspects. Our topic today is very important, which dealing with COVID-19, combating the new pandemic medical challenges and vaccines. Now, we will start our first speaker, Professor Mostafa Alfishawy, Transplant Infectious Disease Consultant, Aswan Heart Center, Egypt. Welcome, Professor Mostafa. Floor is open for your presentation.
Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. I would like to thank all the committee organizing this event today, and especially for Dr. Muhammad Al-Qassas for inviting me to give this lecture. I think that we'll talk about COVID-19 in 15 minutes, especially with all this advancing science and everybody is reading about, but I will try to summarize all what I get in this upcoming 15 minutes. So I am Mostafa Alfishawy, I'm the organizer for IDCare, and this is the first infectious disease society in Egypt. Today is the 4th of June, and we will discuss the basics of COVID-19. I did my internal medicine residency in Mount Sinai University in New York, and I did my infectious disease training in Pittsburgh. So I'm going to start with my agenda. I have today a speech about the epidemiology, virology, infection prevention and control, and management of COVID-19 cases. So in the beginning, coronavirus disease 2019 that was labeled COVID-19 by the WHO. Here, this is an interesting page that's in the Lancet Infectious Disease Interactive map, and you will see that till yesterday there was around 6 million cases, and now there are 303,000 deaths, with almost every country in the world affected. The COVID-19 timeline started on the 31st of December, at that day when Wuhan reported a cluster of pneumonia cases. Then around 6 days later, on the 5th of January, that's the time when they said there is a problem, and they announced that the WHO will go and see what's happening. On the 12th of January, China already did the sequencing for SARS-CoV, the virus responsible for COVID, and on the 22nd of January, they were able to mention that now we know that SARS-CoV can be transmitted from human to human, because previously it was thought that it just came from the food market where they serve like animals, but now they said no, it can be transmitted from human to human. On the 11th of March, it was declared by the WHO as a global pandemic. This disease didn't only cause the mortality that we just mentioned, about more than 300,000 patients, but also it caused a huge economic loss and also a huge mental stress for everybody. I think everybody who is attending now. COVID-19 started, as we mentioned, at the outbreak in Wuhan in an animal market and soon spread to the whole globe. The thing about COVID-19, why it spread that fast in China, because of the increased transfer between people in China, which increased in the last 10 years due to advancement in transportation. And here you will see in the map where the passengers from Wuhan travel all through the China. So you will see that in the western part where they have little travel, that's where they had little affection by the virus. Here, when we compare the SARS outbreak that happened in 2002, you will see at that time the train passengers was like 1 billion and see very little air passengers. But by the time we reached 2020, it almost quadrupled. That's why the disease spread so fast. Here, this example for the strategy that the countries use to manage COVID-19. So to manage COVID-19, the countries had to do certain strategies. First, they thought about containment. where this strategy of containment was to limit the spread of disease and try to do contact tracing for every patient and to admit all the patients and the contacts. But this strategy proved to be unsuccessful. Then certain countries use mitigation. Mitigation means try to just flatten the curve, try to withhold all the patients to your healthcare system. The problem about COVID-19 is it's overwhelming disease. So your hospital will be suffering by many, many patients coming at the same time, so the healthcare system would collapse. So the mitigation strategy used not to contain the patient, but try to limit the spread. How? For example, closing the schools and closing the universities, so that when the patients stay home, when they stay home, this decreases the possibility of transmission. But I think that most of the countries that use this also proved unsuccessful later on, because the problem is that now many literature are saying that using this strategy of closing the school actually didn't help that much. Also, not only it didn't help that much, it caused a lot of suffering, whether economically or mentally. The other strategy, which is suppression, which is like treating as many patients as we can and using all the prior strategies till we reach the strategy of prevention, which will not happen till we have a successful vaccine. But when we say that we will need the mitigation strategy, and we are saying that in the news, people need to know that mitigation means that everybody of us will be infected. The whole country will be infected till we get what we call the herd immunity. The strategies that use, here you will see the European approach where they used lockdown and no masks versus the Asian. In the Asian approaches, you will see that the number of cases were so low. Why? Because they used the face mask and tried to limit the country and try to limit the air travel, but the European countries didn't do that. The reason why the Western countries didn't have that strict, they said that this will limit the freedom of the civilians, but the problem is that it led to rapid rise in the number of cases. But what about regarding herd immunity? The problem about herd immunity is that when people say, yes, 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 I need herd immunity, they don't understand it. It's like a young bachelor who is saying, I want to get married, but when he is married, say, oh, he didn't know what he will be suffering. And that's the same. So herd immunity means at least 60% of the population will be infected, and then the transmission cycle of the virus will end. Till now, did we reach that? No. New York City, in this article published by the New York Times this week, said that only 19.9% had the antibodies. London 17, Madrid 11.3, Barcelona 7.1, Stockholm 7.3. So we are far from getting this. What about the Egyptian numbers? So I was getting the numbers from Cairo University. They said that it increased, about like 1 in 27 were positive in the last 2 weeks, but this week is like 3 out of 27. So we are far away from the herd immunity till now. But first, we need to know about the virus. What's the coronaviruses? So coronavirus is a subfamily of orthocoronaviridi, coronaviridae in the order Nidovirales. These viruses have what they call the spike protein, and this spikes under electron microscope will appear as if it's a crown and or a halo, and this is the corona in Latin. These viruses are RNA with positive sense single-stranded genome, and they are the largest RNA viruses. There are 7 strains with the novel coronavirus or SARS-CoV-2 being the 7th. Previously, there were like 4, and then the new ones, which is the SARS, discovered in the 2002, and then in 2012, the Middle East respiratory virus, which was discovered by our professor, Dr. Ali Zaki from Ain Shams University. So the SARS-CoV has 2 strains, L and S, and this is the picture of the SARS-CoV, where the spike glycoprotein mainly has all the characters for this virus and binds to the receptors, and that's where we get the antibody for the spike glycoprotein, plus the other like the N protein, which we use as a marker in the PCR. The transmission of COVID-19 is a direct person-to-person transmission, mainly through close contact and through respiratory droplets when the distance is less than 2 meters. There was concern about airborne transmission through aerosol generating procedures, which we will discuss a little bit in a while. And also it was detected in non-respiratory specimens, like the stool, the blood, ocular secretion, semen, urine, and in the last 3 days, this recent research about being detected in the breast milk. Also, SARS-CoV can be transmitted from asymptomatic individuals in the incubation period, which is very important because when we need to do any contact tracing. The viral shedding and period of infectivity can occur prior to the development of symptoms and early in the disease, but they did a study in Taiwan where they evaluated 2,500 contacts, and they found that mainly all the infections happened in the first 6 days. That's why they said, maybe we don't need that long time of isolation. Maybe we don't need 3 weeks, maybe you don't need this 4 weeks or even 2 weeks. And then this was de-escalated later on when we will mention the CDC recommendation about 10 days. Environmental contamination is a major route of infection. That's why cleaning is very important in disinfection. And recently, sunlight has been shown to inactivate the SARS-CoV in less than 20 minutes. How contagious is the virus? This is an example. We will see that the virus, how far it can travel. So compared to measles, here you will see that the measles can reach up to 100 feet, but the SARS-CoV can reach only up to 6 feet, which is less than 2 meters. Being measles is the most infectious agent that we know. So if we compare SARS-CoV to influenza, here if you start by 5 people and infectivity of 1.3, by 5 cycle, you will reach around 45 people with influenza. On the contrary, if you start with the same 5 people with SARS-CoV, by 5 cycles, you will reach around 368, which means that this virus is much, much, much more infective than the flu. But if it's infective than the flu, do you think that this is the most deadly virus? No. So here in the example, you will see that our SARS-CoV falls here. So it's not as fatal as the MERS or the avian flu or the Ebola, but also it's more infectious than the MERS and the Ebola. So it's more infectious than them, but it's less deadly, with measles as the most infectious agent that we know, and also the avian flu as the most deadly infectious virus that we know. So how to prevent the COVID-19 disease? First, to prevent the COVID-19, there are vaccines that are under trial. This is from the clinicaltrials.gov. You will see that there are recombinant vaccines that are being studied now. They are studying the BCG vaccines, especially for healthcare workers. Now started for hydroxyprophylaxis. Actually has a study that was released just at midnight in the New England Journal of Medicine that said that hydroxychloroquine failed post-exposure prophylaxis, and other studies that are present like ivermectin study. For infection and control in the hospitals, the recommendation from CDC is to start by universal screening, which we see now in most of our hospitals, that you have a nurse at the entrance of every hospital that instructs all the physicians and the nurses and the visitors and the patients to mask upon entering, and also to test the temperature to know that you're not febrile. Also, for all the hospital, we instruct for universal use of masks, and for dealing with patients or suspects, we instruct them for using gown, glove, mask, and eye protection. N95 mask is used for aerosol generating procedure. So my recommendation is don't use N95 all the time. The reason is that we don't have that much resources. So if you use the N95, I think we will run out of this valuable tool. So what are the aerosol generating procedures that we know? Bronchoscopy, CPR, colonoscopy, using the high flow oxygen, filter change on the ventilator, manual ventilation before intubation, endoscopy, suctioning, tracheal intubation, upper endoscopy, and even swallowing evaluation. The CDC doesn't consider nasopharyngeal swabbing for testing for COVID as an aerosol generating procedure, although some other authorities recommend that. So what the personal preventive measure? What can we do to prevent the spread of disease? So we need to do the social distancing, hand washing, respiratory hygiene, avoid touching the face, and cleaning and disinfecting objects. And CDC last week announced discontinuation for isolation for patients who were isolated either because of disease or they had the positive testing. For symptomatic patients, they now did 2 strategies, the test-based strategy and the symptom-based strategy. The test-based strategy, in which they mentioned that to go out of the isolation, you need resolution of fever, improvement of respiratory symptoms, and negative results of PCR twice separated for the 24 hours. But if you will not use the PCR, then you have to stay for 10 days with at least 3 days of being without any symptoms. How about reinfection? I don't want to talk about it because as you can see here, whenever anyone will have any case of a suspecting reinfection, they will announce it and cause a panic for the whole world. Till now, it's not proven this reinfection, and most of the cases that claim that they were reinfected, they have a negative testing in between that was false negative. So till now, it was not proven this reinfection thing, and if reinfection happened, I think this disease will be a nightmare because it will never end. But now it's not proved. Here, this is the most important slide in our lecture today. So this slide is talking about the pathophysiology of COVID-19. So here, to understand what happened in COVID-19, you will see that this disease takes two phases. The first phase, which is the viral response phase, and the second phase, which is the host inflammatory phase. So the first phase is the phase where the virus enters the body and start multiplying. And then the second phase, it's a phase when the body will have an immune response and then start fighting. The problem about this virus is that the immunity will not be kept at check. The immunity will override. The immunity will be firing. A picture of iris for those who have seen transplant patient or HIV patient, the immunity will flare and it will not be stopping. So what happened is that patient die from their cytokine storm. You will see a cytokine storm in the lung causing hypoxemia, ARDS, and shock. So the most important thing is that to understand the phases of the disease. So in the viral response phase in the beginning, that's where the patient have constitutional symptoms, dry cough, diarrhea, and headache. And then there will be a phase in between where you will notice that patient symptoms may be mild. So whenever you come to you, you will see that most of the patient will tell you, the cough started around 10 days ago, it remained for 3 days, and then 2 days I was fine, and then the fever returned again, or the cough returned again, or I felt sick again. So this is the two phases of this disease. And it's important because in the phase, the first phase where you will have the viral replication, that's where you need the antivirals, and that's where you need to reduce immune suppression for immune suppressed patient. And the second phase, when there is a hyperimmune response, that's where you need to decrease the immune response, either by immunomodulatory treatment, steroids, tocilizumab, or convalescent plasma, or whatever. Here, this is the pathophysiology regarding the disease, and here if anybody of you works in like an isolation hospital, it's very interesting to see the patient. I like to go and see the patient, talk with the patients, and then I noticed that this disease, you will see that the patients are like clusters or groups. You will see that you will have an asymptomatic patient or mildly symptomatic or the thrombophilic patient. So this patient will just come with thrombophilic symptoms, either DVT or pulmonary embolism with elevated D-dimer and the hypercoagulable state. Or you will have the inflammatory patient, you will see the cytokine storm with fever, fatigue, malaise, and all that. And when you work with the patient, you will see that patients are like groups. So you need to identify which patient belongs to which group so that you target the symptom. Hopefully this will be in further research. What do the patient present with? I think everybody, you know that: fever, fatigue, cough, anorexia, diarrhea, dyspnea, myalgia, anosmia, and dysgeusia. A typical picture can happen with COVID-19, either multi-system inflammatory syndrome as in PEDS, Kawasaki, Guillain-Barré syndrome, stroke, thyroiditis, type 1 diabetes, ITP, arthralgia, rhabdomyolysis, hepatitis, zoster-reform rash, urticaria, COVID-2s, many, many, many. And I think that this disease will present as anything. The spectrum of disease ranges from mild, moderate, severe, and critical, where mild and moderate cases represent around 81% of the patient. Severe patients are like 14%, and critical patients are like 5%. The risk factors for getting severe disease: cardiovascular disease, diabetes, hypertension, lung cancer, chronic kidney disease, obesity, and smoking. From my little tiny experience, remember obesity. Obesity is a major risk factor, and unfortunately most of my patients who had like very bad outcome or died, they were obese. So remember, for all our young physicians who are treating COVID, whenever you see a patient that is obese, take care, because this patient may actually deteriorate. we have also other indicators for worse outcome. Here in the labs, and that's why we order these labs for the patient. Lymphopenia less than 800 is a marker for worsening. That's why we need to order CBC. Elevated liver enzymes is a marker. LDH is a marker. CRP more than 100 is a marker. D-dimer more than 1 mic is a marker. Elevated PT, troponin, CPK, and acute kidney injury. How diagnosis was COVID? So this is a sentence I got from UpToDate, so everybody of our colleagues need to know this. People should diagnose patients with COVID when they have compatible clinical picture in areas of community transmission, even with negative testing. So actually, you don't need to do PCR to diagnose. If the patient, now we have community spread in Egypt. So whenever you have community spread, you don't need PCR for diagnosis. A typical signs and symptoms is equivalent to diagnose COVID-19. PCR, of course, is the gold standard with a variable sensitivity ranging from 95% in BAL and up to 32% in oropharyngeal swab. And you need to know the cycle threshold, and serology is not recommended by WHO for diagnosis. Serology till now is recommended for epidemiological studies, as we just mentioned in the herd immunity. So here, I guess everybody have seen this, the time period when the PCR is positive. In the beginning, usually all the tests are negative, and then PCR will later be negative and antibodies will be positive. But here, this is the cycle threshold, which is actually done in all PCR labs, and I need your lab to report it. We found that in this study published in the European Journal of Clinical Microbiology and ID, is that at the level of 33, when you know the PCR has cycles, so when the cycle is 33 or more, we found that this virus is actually non-infectious. It's a viral particle. So PCR detects live virus and dead virus. So at the cycle threshold of 33, actually I can get patients out of the isolation. So this is a valuable tool to decrease our load in our hospitals. Imaging, I will not talk much, we have a lecture about, but we know that chest X-ray can be normal, early or in mild disease. CT is more sensitive and also may appear later, but I need to point out CT angiography and lower extremity duplex because of the incidence of venous thromboembolism. The treatment of COVID-19, diverse number of agents are used. It starts with the SARS-CoV entering the cells through the binding to the ACE2 receptors, so it can use Camostat or Arbidol. Usually it's not available in Egypt, but available in other countries. But after that, this membrane fusion and endocytosis, I can use the chloroquine and hydroxychloroquine, and this inhibit the viral entry and endocytosis and raises the pH, so it inhibits the division of the virus. Then afterwards, I can use lopinavir or darunavir. Here we have in Egypt lopinavir, ritonavir, which is boosted lopinavir, what we call as Kaletra, although recent studies show that the next thing is to use Kaletra combined with interferon and ribavirin. Darunavir is also a protease inhibitor used in people who work with HIV, know it so well. It inhibits a chymotrypsin-like protease, and later on we can use ribavirin, remdesivir, the new agent, or favipiravir. The hydroxychloroquine, now we have seen many problems. We have seen in literature what I call the hydroxychloroquine war. So the hydroxychloroquine war, some published literature say the hydroxychloroquine is wow, it's a valuable drug, and other published literature said it's not effective and it's also causing more mortality. But here our doctors are saying, no, it's causing much patient to improve. We will not take those published literature. Maybe they were funded by pharma. So what we do, we will continue using the hydroxychloroquine. But what I need to point out here, I need to try to match both points of views that we understand what's the problem with hydroxychloroquine. So in Egypt, we treat with hydroxychloroquine asymptomatic patients, mild patients, and moderate patients, and severe. So if we just said that asymptomatic and mild may represent that like 81% of the patients, so it will be logic that people will improve with hydroxychloroquine because they will improve anyway. But do you think that our experience is different? Yes. So I have a paper here. So this paper is very valuable. So hydroxychloroquine was shown to inhibit TNF-alpha for patients who have already high TNF-alpha. And this was proven in SLE patient. And this study was done by Kamel et al., published in Cytokine in 2018. It found that Egyptian transplant patients and donors already are high producers of TNF-alpha. So if I say that some foreign literature are saying that hydroxychloroquine is not helping all the patients, maybe why we are benefiting from this drug is that the Egyptians are different by being hyper producers of TNF-alpha, and this drug actually works for hyper producers. So how to solve or how to end this thing? We need a randomized controlled trial in Egypt to see if this drug really works or not. My little teeny experience in the ICU, it didn't work with severe patients. It was bad. But maybe in moderate cases, it will be good. But I don't take my experience. I take published literature. So we have to do our own data and our own clinical trials. But if you want to ask me, what is the game changer in the management of COVID-19? I would say anticoagulation. So this study was done in Mount Sinai, and they found that there is marked difference in mortality after initiation of anticoagulation when they found that patients with COVID-19 have an hypercoagulable state and they have venous thromboembolism with DVTs and pulmonary embolisms, and even autopsy studies that was done in Germany showed that patients, almost more than 50%, and some studies said 30%, have venous thromboembolism. And now, after we started the anticoagulation, after recommendation from our group from ID Care, I think the outcome in Egypt flipped. Now we have better outcome due to increased use of anticoagulation, and I was very glad that was introduced in our Ministry of Health protocol last week. How about steroids? Steroids as immunomodulatory agent are important, but the same thing, I say the timing. You need to understand the timing. And this is what I wrote as a personal communication with the lead author in this CID article about using steroids. So how to use a steroid? You need a short course of methylprednisolone, 1 milligram per kg, 3 to 7 days for non-ICU, 3 to 5 in non-ICU, and 5 to 7 in ICU patient. Which patient? In patients who have exertional dyspnea or exertional hypoxia. So Dr. Ramesh, when he sent me an email, he mentioned that whenever you have a patient with hypoxemia, this is the patient actually that will benefit from the steroids as the immune modulatory. But what about tocilizumab? Mixed studies. This is the study that was published last week, and this is the Italian group. They said that although this tocilizumab as an anti-interleukin-6 helped patients in increasing the improvement, it was not statistically significant, and also it decreased the mortality, but also was not statistically significant. My experience, I had 4 patients who received tocilizumab in our ICU, and it was marvelous. So convalescent plasma, which is an investigational agent, now many trials, including the Solidarity trial by the WHO. I was happy that in the last week, Ain Shams University and Cairo University announced that they will be starting giving convalescent plasma. I know that it was used previously in isolation hospital in Egypt, but on a low scale. Now it will be widely used. This convalescent plasma had many studies that supported, although some other studies were not that supportive, as all the agents in the COVID-19. So all our treatments are under trial. Unfortunately, we don't have a fixed agent that we know that's proven and effective, but we know that immunomodulatory treatment is important, and our game changer is the anticoagulation. My take-home message is COVID-19 is a highly infectious disease. COVID-19 is a multi-system infection. Anticoagulants and immunomodulatory are the mainstay for treatment. Medicine after COVID-19 will never be the same, and thank you.
The next session, we have Dr. Dietrich from Germany. Dietrich is a radiologist in Martin Luther University, Germany, and he is going to talk about the CT scan during the COVID-19. We will have an introduction from Prof. Maged Negm. Kindly start, Prof. Maged.
It's our pleasure now to welcome His Excellency Professor Dr. Khaled Abdel-Ghaffar, Minister of Higher Education, and we'd like to thank him very much for joining us here. And as I mentioned at the early beginning, he is very keen to join us, not just to give his welcome speech, but also to interact with it. Welcome, Your Excellency, Professor Khaled.
Thank you, Dr. Maged, for inviting me. It's a great pleasure for me with you today in this important virtual meeting about combating the new pandemic and the medical challenges and practices. I really enjoyed the first lecture. A great effort by yourself and your team and Helwan University. Let me start by welcoming all our esteemed guests and esteemed experts from different parts of the world participating with us with their knowledge in this important virtual meeting. I think we have all agreed that what we are seeing today, this is an unprecedented event that affected largely all the world, not just Egypt. And this outbreak of COVID-19 pandemic changed a lot of aspects in different parts of the world. So I believe we have to sit together. We have to learn from each other. Solidarity in this crisis is the game changer for combating this important pandemic. So I think let me just take you to the history when we just first received the very first case on February the 15th. And since that time, the Egyptian government, under the direction of President of Egypt, has taken many necessary steps to control the spread of this pandemic. And this response was in a very strategic way and in different aspects of life, started from suspending education in schools and universities, in different parts of the workforce, in lockdown of different aspects of life, in sanitizing public spaces, and the temperature of all sorts of gathering, as well as plans for safety living that we have to plan for the future. On the other hand, I think the Minister of Higher Education and Scientific Research has assumed also a crucial role in this front line. Academically, by switching the traditional in-person and on-campus education to an online and remote communication, it was started as early as the 15th of March. And this allows, and we also allow many workers to conduct their work from home. And we cared a lot about the safety of our faculty, staff, and certainly our students by doing that. The ministry also encouraged scientific and academic research related to COVID-19. And as of a couple of days ago, the number of clinical trials reported from Egypt as 50 clinical trials around COVID-19 research. And this included and not limited to potential cures or solutions or sequential or genetic sequencing of the virus, treating and trying different treatment modalities, a lot of efforts in vaccination and other related work. On the other hand, as a medical and social front, also the minister through the university hospitals also contributed with a lot of effort in terms of participants within the Minister of Health that works together and in hand in different isolation and quarantine hospitals and also in isolated spaces. This is just only some examples of how Egypt responded to this unprecedented situation. And I think the whole government and the Minister of Higher Education in particular, with the help of our colleagues from different universities, they are doing a great job. They're doing a marvelous job. And together with our professors and doctors and nurses and technicians that work on the front line to combat this pandemic, trying to control. So as you can see, this important meeting I really appreciate, and I want to acknowledge the effort from Helwan University to virtually held this successful conference, and at the same time to welcome all the contributions and the expertise of our distinguished participants in the four sessions of the conference, which I believe that the scientific session has been selected in a very important way. I wish you all the best, and I wish for the conference a great success. And thank you again for inviting me. Dr. Magid, back to you.
Very much. And we are going to continue the discussion, and I will leave the moderator, Professor Mamdouh, to actually introduce our next speaker, Professor Dietrich from Germany.
Thank you very much, Dr. Magid. This is Dr. Dietrich from Martin Luther University. He's with us now. He's going to talk about the CT scan during the COVID-19 and he will transmit experience of Germany, radiological examination due to the COVID-19. Dr. Dietrich, you can share in and begin your lecture. Thank you.
Thank you very much. Okay, thank you very much for your kind introduction, and thank you for very interesting lectures so far. I would like to talk to you about COVID-19 through the eyes of a radiologist. We have had some experiences with the disease by now, of that are infected or affected the world. But in Germany, you can see the outline of the state in which Halle is located here. So we are right in the middle of Germany, so to say. But the state of Sachsen-Anhalt has very few cases compared to the nationwide diseases. That's probably because we have very few people returning from their skiing vacations in Austria. So we have fewer cases than Bavaria. And in the town of Halle, so far we have 352 cases as of yesterday, with no more cases today. 6 are still in hospital, and we had 12 deaths within the city limits. The mayor said that 10 of them are not due to COVID, but they, while also contracting, those were very old, very sick people who were already nearing their deaths. So we had few cases in Halle, fortunately, because we went into a lockdown very early, and we are just emerging from that during the last few days, and so we had very few deaths as well. If you look at COVID-19 from the perspective of a radiologist, this is a recent Medline research for computer tomography and COVID-19. There were only 2 publications in 2019. Now we have almost 800 publications so far, and most of them are hastily drafted, so their quality, of course, nobody had time to do a double-blind trial yet. We have very many publications, but as I will address later on, the quality is not as good as we would like to. So what do we see? We see in the different stages, we see different affections of the lung with our CT. So we have an early stage from day 0 to day 4, where we usually do see a peripheral ground glass opacity. If we see anything, there's of course affected people who don't have a viral pneumonia. During the progressive stage, we see a ground glass opacity with thickening. So that's called crazy paving. This is a paving our students and the doctors who are not from the radiology department usually have trouble identifying the craziness of this paving. But I guess if you see the real photograph, you can assume how it came to that name. And during the peak stage, we have consolidations. What's ground glass opacity? I don't know how famous the Simpsons are. If I have to explain it to German doctors, I usually use that picture. So that would be Mr. Burns, and that would be ground glass Mr. Burns from The Simpsons. So you can still see the outline, as you can see the bronchiovascular structures in the lung, but there is a hazy attenuation laying over the structures, and that's the definition of ground glass opacity. So, as I mentioned earlier, we do have crazy paving which is a ground glass opacity with its thickenings in between, and we also have signs like the reverse halo, where you have a attenuation, a higher density halo around the actual structure. And this is from a colleague from Hanover, who was kind enough to lend me those pictures, because this patient actually does have all the patterns within one picture. So what you see is that it's usually reticular in shape. You see the peripheral distribution of these. You can see the bronchial value of diseases of the lung, because of course these are not specific for COVID-19. So if you look at the publications, there have been a multitude. So I can go only into these two, which are probably the ones with the highest quality, because, or the number with the publication with the highest number. This second report included over 1,000 patients. And so if you look into their charts, you can see that they tested, this is a higher quality publication with fewer cases. They tested and they performed chest CT. Most patients who were identified as COVID-19 patients later on had both a positive PCR and a positive CT scan, but there are patients which do have a negative PCR and positive CT scan, and of course we do have negative CT scans on initial presentation, because these patients do not have viral pneumonia. But this is probably one of the most important take-home messages. While it is, of course, a PCR diagnosis, and will always be, we do have negative tests, sometimes due to false negative testing, sometimes due to false sample taking. And in these cases, CT scans might be an additional value. The other previously mentioned publications by I included more patients, and they had a high number of patients with a negative PCR and positive. You can see 300 out of 1,000 previously tested negative with PCR, but had a positive CT scan. The problem with this publication is that they didn't specify what's a positive CT scan, and the CT was taken up to 7 days later after admission. So probably a lot of these patients were also negative on CT and contracted the disease within the hospital, or were infected but didn't had an outbreak yet. So this number is way too high. But again, we have some patients who have a positive CT scan and a negative PCR. So if you want to look into that a little further, there's a good publication which contracts all the information published in the American Journal of Radiology in April, which goes into that. And so most of the radiology societies published statements that we do not see CT as a primary screening tool for COVID-19, but we see it as an additional information to confirm diagnosis of viral pneumonia. What about the radiation dose? These are this is data from America, from the United States, but it's also true for Germany. Most of our medical radiation comes from CT scanning. So what would happen if we increase this number of CT to all the patients suspicious of COVID-19? We would increase the radiation dose to our population quite a bit. So usually what we do is we use a low dose protocol with only 0.3 microsievert, which is approximately, depending on age and your weight, 15 chest x-rays. Still higher than a normal chest x-ray, but much lower than a normal CT. So we will increase that, but not as much as one might be afraid. So our protocol consists of a non-contrast enhanced CT of the chest. We try to reconstruct very thin slices. We use only 100 kilovolts, and we have a modern CT scanner. So depending on the mode we use less than a second to acquire those images. So we are not dependent on the patient holding his breath very long. So what about chest x-rays? This is one patient with COVID-19 presenting on a chest x-ray on the left. Could argue that there might be some consolidation down here, but in this area, you do not see all those ground glass opacities. So chest x-rays are good for seeing complications within the patients. You see the larger consolidations in the later stages, but you are not able to see those ground glass opacities. So we suggest, if available and if possible, use a CT scan. So I'm already down to my take-home messages. PCR is the reference standard and will always be, because it's a viral disease. But know that PCR can be falsely negative depending on the test you use. So in uncertain cases, one might tend to use a CT scan to confirm viral pneumonia. All societies I know of say that CT should not be relied upon as a primary diagnostic screening tool. If you look at a CT scan, know that there might be not a confirmed COVID-19 case yet with PCR. So look for peripheral ground glass opacities, crazy paving, and this reticular pattern. So that's something where you can be quite certain that you have a viral pneumonia, and at the time, it's usually COVID-19. I'm part radiologist, partly I run a teaching hospital and a skills lab. And so I also wanted to show you something where we can actually help the medical community with in this pandemic with teaching. So my last slide is about that. This is actually an actor. We're not allowed to do our final medical exam in hospitals anymore because we were afraid that the student back some might infect our patients. So we switched our state examen to actor. And this is an actor with a dermatological disease. This is not real. This our dermatologists say it looks real. It's supposed to be a zoster. I'm not certain, herpes infection of the skin. And so we are now able to test medical students outside the hospitals with real, almost real cases. That's one thing we can do to help. This is our virtual reality room where we can actually do teaching in a virtual reality surrounding. This is not a photograph of a flat. This is a virtual reality, like a video game. So we do teachings there. We also introduced telemedicine teaching. So now we have patients talking to medical students outside the hospitals. They can do rounds on wards. They can talk to real patients, but stay outside the hospital, not contaminating patient rooms. And we also did a lot of 3D printing in teaching. And now we use those 3D printers for person protection. Those are visors to screen from infections. Thank you for your attention. Thank you very much.
Okay, thank you, Professor, about this interesting lecture. I have a couple of questions. The first question, you talked about consolidation and ground glass opacities and the crazy paving pictures on the chest CT. Have you ever tried or encountered using artificial intelligence in diagnosis of such cases in order to get precise diagnosis? Since you mentioned that you cannot rely on the CT pictures and on the diagnosis. I totally agree with you. However, I've read that with some artificial intelligence technology, I think the sensitivity of diagnosis could be enhanced in a very good way. This is the first question. Mm-hmm. The second question is about, have you ever encountered research looking at recovered patients? Because there is a lot of talks about the damage, the permanent damage that will occur on the lungs in terms of fibrosis and other things after patient recovered from COVID-19. Is there any research behind that, or most of the time the patient can be recovered totally with any signs of chest or lung damage after recovery? Thank you very much.
Concerning your first question, artificial intelligence, I've seen some smaller papers, which again, like all papers about artificial intelligence, can increase the diagnosis. But as far as I know, we don't have a collective large enough yet to train the artificial intelligence on that. But there's a lot of papers on intelligence. The artificial intelligence is now reaching expert levels in dermatology concerning melanoma, in radiology concerning breast cancer. So most certainly we will have artificial intelligence with much better than normal radiologists will have. Most papers I read about artificial intelligence, they said that an expert using AI to rethink his own diagnosis usually gets better results than anything. And I guess this will be the same with COVID-19, but haven't used it on those cases yet in Halle. Concerning your second question, what we do see is we have very little data. As I said, we only have 6 patients left within the hospital. Usually the lungs recover quite well. What we do see is an increase in cardiac damage, myocardial infarctions and stroke. So probably there will be emerging data within the next month where we will look into persisting damage, not to only to the lungs, but most certainly to the heart and to the brain. But I haven't seen any data on that in a larger publication yet.
Thank you very much.
Thank you, Your Excellency. Back again to Dr. Mamdouh.
Thank you so much for our first two presenters, Dr. Mostafa Alfishawy and Dr. Dietrich. I wanted to ask two questions for Dr. Mostafa. What about the convalescent plasma transfusion? Your experience regarding such point for treatment of the patients with COVID.
See.
Second question for Dr. Dietrich. I wanted to ask about the dilemma of the PCR and the CT. How we can depend, especially we have a shortage of testing for the PCR for the patients and the time consuming, and the CT is positive. Can we start our procedure regarding the isolation and treatment?
Well, I'm not an infectiologist, but if you do have, if you see the changes I showed you, if it's not just area of ground glass opacity, but if you have signs of pneumonia, I guess at this very moment, you can be very certain that this is COVID-19. At least in Germany, we don't have many other things around causing viral pneumonia at the time. But of course, this is not specific. So if you have different diseases affecting your population at this very moment, that also cause viral pneumonia, the answer might be different. But as of now, we don't have a cure. So I guess you would treat the patient with as a viral pneumonia as soon as you have the CT scan.
Very much very informative and present. I think we will shift now to our next speakers. Dr. Kassas will present him.
Yes, now it's my pleasure to present Professor Koichi Watashi from the National Institute of Infectious Diseases in Japan, who will present us the identification of anti-SARS-CoV-2 drugs and their possible application to COVID-19 treatment. Professor Watashi.
Good morning, everyone. Actually, good evening here in Japan. Yeah, so today I really appreciate for giving us an opportunity to present our study and to seek for a possible collaboration between Egypt and Japan. So today from Japan, I will talk about the identification of approved drug having capacity to inhibit SARS-CoV-2 proliferation from a basic biological side. And after that, Dr. Shingo Iwami will talk about the prediction of drug efficacy in clinical settings from a mathematical analysis. So actually, yeah, I'm very lucky to manage such a big collaboration project with many researchers from different fields, including not only biology, but also biochemistry, informatics, pharmaceutical company, mathematics, and clinical researchers. And I really appreciate their effort in this research. So, okay, this is a general scheme for drug development, as you know very well. So you develop new drugs by following these schemes, including the identification of these compounds in the basic study and optimization in basic and preclinical phase, and validation of their antiviral effect, and also the adverse effect in clinical study to be approved for clinical use. So by this method, you will have a strong first-in-class drug, but this takes much time, at least in average more than 10 years, and it is costly, and the probability of drug development is extremely low. So in the situation of the pandemic of COVID-19, we don't have much time. So the alternative strategy is the drug repositioning program, in which you use the approved drug for any diseases, say hypertension, diabetes, allergy, and so on, and evaluate these drugs on the COVID-19 replication. To do so, you can achieve a rapid and less costly drug development. So our aim of this study is to identify compounds from non-approved and also approved drug suppressing coronavirus proliferation. But today I will briefly introduce about our drug repositioning study. So for rapid drug discovery, we have a large collaboration including the pharmaceutical companies and the academic research institute and the universities. And from approved drug or unique compounds developed by their own technology, we aim to identify the antiviral drug. So we mainly use the infection cell culture assay that we have already established. So now you have viral susceptible cells called VIRO-E6 TMPRSS2. And this cell line was treated with the SARS-CoV-2 isolated from a patient in Japan in the presence of compound library. And after that, we evaluate the cytopathic effect induced by virus proliferation of this cell line. Because once the virus proliferate in the cells, the virus kills the cells like this. So if your drug inhibits the virus proliferation, you can see the protection of the cells from cytopathic effect induced by virus proliferation. So in such a strategy, what we did is to count a survival cell number. And if you have a higher survival cell number, you can count as a hit. So initially, we screened about 300 compounds that is approved, but now already completed more than 3,000 compounds. But today's result is the one from the initial screening. And for all 100 compounds, we found 5 hits shown here. So lopinavir is, already expected as a candidate of anti-COVID-19 drug under clinical trial. And rapamycin and lotepredonol, can suppress the immune response in your body. So what we focus on is the remaining two compounds, nelfenavir, which is originally the anti-HIV drug, and cefalancin, which is an anti-inflammatory drug. So in the lower panel, you can see the effect of these compounds on expression of virus protein. So the virus protein shown by red here can be seen in infected cells as shown here, but not uninfected cells, of course. And the treatment with the drug candidate, such as lopinavir and chloroquine, but not favipiravir, reduce the virus expression level as shown here. And our drug, nelfenavir and cefalancin, almost completely reduce the viral expression level. So we treated with these compounds at different concentration, which is shown x-axis. And the y-axis shows the viral RNA in logarithm scale. So both of nelfenavir and cefalancin dose-dependently reduce the viral load. And IC50 and IC90, which is the concentration required for the inhibition of the virus to 50% and 90%, is also shown here. So if this value is low, that drug have a high antiviral activity. So we compare the IC50 and the IC90 of these two drugs with the expected drug candidate. Just and you can see that these two drugs has a stronger antiviral activity, at least in cell culture assay. So what is the mode of action? So we did both the virological assay and in silico assay. So although I don't mention much about this virological assay, the nelfenavir effect is resembled to that of remdesivir, which is a replication inhibitor. And the cefalancin effect resembled to the chloroquine, which is known to be an entry inhibitor. And in another approach, we did an in silico assay. So this ribbon shows the viral main protease. And our collaborator screened the compound that can bind to the main protease by this docking simulation, and found that nelfenavir can bind to the viral main protease. So these data suggest that nelfenavir is likely to bind to the main protease to inhibit viral replication. So the situation is like this. So virus enter into the cells and replicate in the cells to be produced outside, and the main protease is likely to be inhibited by nelfenavir, because the nelfenavir itself is originally established as a protease inhibitor of HIV. So what is the mode of action of cefalancin? So in silico docking simulation analysis shows that the cefalancin can bind to the SARS-CoV-2 spike protein, which is resided on the surface of the viral particle that is essential for the receptor binding required for the viral entry into the cells. So the mode of action is different. So in general, I'm a biologist. So in general speaking, the improvement of antiviral therapy can be achieved by multi-drug treatment. In the case, for example, in the case of AIDS or hepatitis C treatment, as you know. So we did a co-treatment analysis and show that if you look at this graph, you can see a synergistic effect shown by orange in a large area of the concentration of nelfenavir and cephalancin, showing that these two drugs can achieve the synergistic antiviral effect. So our question is that these drugs really effective in clinical settings. So you will know by clinical trial, but before that, we predicted the antiviral efficacy by mathematical analysis. The detailed analysis will be mentioned by Dr. Shingo Iwami after me, but in the principle, now we have the response curve of the drugs, and the pharmacokinetics information in patient is already available because these are the already approved drugs. And in patient, the max, which is the maximum concentration of nelfenavir, is about 4.52 micromolar, and C-trough, which showing the lowest level of the concentration is 2.11 micromolar when adopt 750 milligram 3 times per day. So the clinical concentration range is here, showing that the nelfenavir can achieve the enough antiviral effect, because you can see about 3 log reduction by these concentration. So in detailed analysis will be mentioned by Dr. Iwami. And so, yeah, in such a way, we identify the antiviral drug by using Infectious cell culture system, and the paper is already available. So multi-drug treatment with cephalancin against COVID-19. So my message is that the combination of replication inhibitor and entry inhibitor can exhibit the synergistic antiviral effect. Yeah, it's okay, but one possible improvement is that cephalancin is unfortunately the injection drug when you want to achieve enough antiviral effect by this drug. So our next question is that is the entry inhibitor replaceable to an oral drug? So to address this question, we screened more drugs, and this is one example. So hydroxychloroquine is, the entry inhibitor, but their activity was high, at least in our cell culture assay. So if you treat 8 micromolar here, the hydroxychloroquine did not rescue virus-induced cytopathic effect. But several chloroquine derivatives is already available for approved drugs. And so we are lucky that one approved drug, that is chloroquine derivative, nicely protected the cells from cytopathic effect. And also this drug greatly reduced viral protein. Yeah, the reduction of a viral protein can be seen by hydroxychloroquine, but it's much more. And when you look at those response curve, this is that drug, and this is hydrochloroquine, showing that this approved drug can show the stronger antiviral effect. And the clinical drug concentration range is here. So reduction of viral level can be expected in the clinical drug concentration range. So I will mention about the further information actually tomorrow in the more closed meeting with Professor Mohamed El Kassas. So this is a summary of my talk today. So we identified approved drug having a significant anti-COVID-19 activity. So nelfenavir as a replication inhibitor and the cephalancin as an entry inhibitor. And also, if you combine these two drugs, you can show a more a stronger antiviral effect. And significant antiviral effect was predicted to be seen by nelfenavir and the cephalancin in the clinical setting, at least when you compare those response curve and the pharmacokinetics information in patient. And also a chloroquine derivative can be used in place of cephalancin. So this information, we hope this information is useful to plan a clinical study having better outcome. Thank you very much.
Thanks a lot, Professor Watashi, for the elegant presentation. And let us complete the story by the talk from Professor Shingo Iwami from Kyushu University, who will present us the prediction of antiviral treatment efficacy of the drugs through mathematical modeling. Discussions will be for both lectures by the end of the lecture of Professor Iwami. Yes.
Okay, I'm Shingo Iwami from Kyushu University, Japan. Thank you very much for giving me this great opportunity to share our recent research. My title is this, but please do not care about my title. I'm going to explain the theory part of the Koichi's talk in detail and as easy as possible. I try my best. And so in my talk, we are going to focus on only these two drugs, nelfenavir and cephalancin. And so again, I would like to explain this data in detail. And you can see, so this is we call dose response curve, because this x-axis is a drug concentration, and this y-axis is a replication of the virus. So if you see that there is no drug around here, the viral replication is high, and we normalize this as 1. And as drug increase, the replication level decrease like that. And this is for those response curve for the nelfenavir, and this is for the cephalancin. And so we can see those dependent antiviral effect of nelfenavir and cephalancin, and we probably expect that considering the drug concentration is quite important. And also here, so I would like to define the antiviral effect of nelfenavir and cephalancin as FUA and FUV. And here, D is a drug concentration. So because of this FUA is antiviral effect, so 1 minus FUA represents the replication of the virus. So as you can see, as D decrease, this 1 minus FUA decrease because FUA is increased. And as Koichi explained, the antiviral, the mechanism of each drug are different because nerfinavir inhibits the viral replication because of nerfinavir is protease inhibitor, and cefalantine can inhibit the viral entry. And so we can expect the combination of nerfinavir and cefalantine might affect synergistically. So using a mathematical modeling, we would like to quantify how the combination of these two drugs can, enhance the antiviral drug compared with the expected antiviral drug. And then I would like to show this these panels. And left panel is experimental data from Koichi's group, and this is called matrix plot. And so this axis is a drug concentration of nerfinavir, and this axis means drug concentration of cefalantine. And each color of the matrix represents the antiviral effect. As you can see, the red color represents the high antiviral effect, and green color represents a low antiviral effect. And this is a real data obtained from experiment. And also, we had a classical drug combination theory, which is called Bliss independence. And here, this is very simple because we have already know FAD and FBD from this single drug experiment, and we can calculate the expected antiviral effect using the combination of cefalantine and nerfinavir. And this right panel represents the expected antiviral drug considering the Bliss model. And then we would like to quantify how this combination enhance the antiviral drug. And so we just compare this real experimental data and our prediction predicted by the Bliss model. And as Koichi said, so this is the quantification for synergy effect of drug combination. And as you can see, the red color, the darker red color represents the synergistic effect. And this axis is drug concentration, concentration of nerfinavir, and this axis is a concentration of cefalantine. And we just calculate the antiviral effect in experiment over the expected antiviral effect by Bliss independence. And some area, some drug concentration range show something blue color, but this is very low drug concentration. So basically, the clinical drug concentration is much higher than here. So we can expect the drug combination with nerfinavir and cefalantine show the synergistic effect as our experimental and mathematical analysis showed. And so we now confirm that probably these two drugs will interact synergistically. And then we would like to understand how the antiviral drug can suppress the viral replication, viral load in the patient when we use a single use of the nerfinavir and the combination of the nerfinavir and cefalantine. And we have already know the pharmacodynamics information from the Koichi's experiment, which is called PD. And also these two drugs have already been approved. So we have the information for PK, which is pharmacokinetics, the drug concentration depending on time. And we already have the PK and the PD information. And also our group are preparing the clinical data from the published the paper from this COVID pandemic. And we have already 38 patient clinical data. And also we can make a mathematical model describing the viral infection, which is called viral dynamics. I would like to explain a little bit about the viral dynamics. So we simply consider the uninfected cell, which is target cell, the cell representing the S2 receptor, for example, and the infected cell and the virus. The virus can infect target cell, and then infected cell produce the viruses, and these viruses infect the target cell again. So this is called viral dynamics model. And we can make the simulation using this viral dynamics model without drug and with drug. So the nelfinavir can inhibit the viral replication because of protease inhibitor, and also cefalexin can inhibit the de novo infection because this is an entry inhibitor. So we can couple all these information that is PK and PD and VD dynamics. And we have already established that kind of simulation in silico, and we can predict the outcome of the drug treatment on the viral load. And in the next 5 or 10 minutes, I would like to explain our prediction. But before that, I would like to explain how we evaluate the antiviral drug therapy in terms of the viral load. And so this is the kind of figure, and you can see, so without drug, this black line is a viral load, and this y-axis is viral load, and this x-axis is a time from the symptom onset. So we assume that time 0 is symptom onset. And if we initiate just after the symptom onset, if we initiate the drug treatment just after the symptom onset, the viral load will decrease if the drug can inhibit the viral replication or the entry. And so our index, one of index is a cumulative viral production. So which is correspond to the area under the curve of this viral load. So without treatment, you can see this orange part here. This part is an area under the curve of the before the viral elimination. So we use this, and also with a treatment, so this viral load decreases like that. In that case, the area under the curve could be this green part. So we are going to compare this area under the curve to evaluate the antiviral drug on the viral load. And another index is time for viral elimination. So without drug, we can see the time for viral elimination is this orange arrows, because this dot is a detection limit. And with treatment, the time for the viral elimination changes to this green arrow. So we can calculate the difference of these two arrows, and it could be reduction of the viral elimination. And using these two index, we are going to evaluate the antiviral therapy in silico. And so we have already, as I explained, we already obtained the pharmacodynamics, which is an antiviral drug depend on the drug concentration in our experiment. And we have the PK information, which is a drug concentration depend on time. So we can couple these two information, and it is called the PK/PD information. And the left figure is for nelfinavir, and the right figure represents cefalexin. And this box is a zoom of this area, but you can see this panel. And the nelfinavir and cefalexin has already approved, so the regimen is also decided, so we use a standard regimen for each drug. And then, as you can see, especially for nelfinabine, the antiviral effect is maintained at the quite high level. But on the other hand, cefalantine, if we use this regimen, the antiviral effect is sometimes decreased because of the drug elimination. And so we can calculate antiviral effect in vivo, for example. And in addition, we can couple this PK/PD and our viral dynamics modeling, and then we can obtain the prediction for the treatment using nelfinabine or single use of cefalantine and a combination of nelfinabine and cefalantine. And the black line in these three panels are completely the same because this is the predicted viral load without treatment. And this line represents the detection limit. And if we use nelfinabine with the previous regimen, when initiated here, and we can get this prediction. And this is for cefalantine, and this is for the combination of nelfinabine and cefalantine. And of course, here we just, for our simplification, we just show the mean of our estimated parameter, but from the around 40 patients, we can get the parameter distribution for each parameter. So we can do the Monte Carlo simulation, and we can obtain some different heterogeneity the patient. But today I just use this simple median, the result of our simulation. And now we are going to calculate two index, which are introduced in here. And one of them is cumulative viral production. This is the area under the curve. So without treatment, the cumulative viral production is here. But if we add single nelfinabine or single cefalantine or a combination of cefalantine, so we can see that this treatment drastically reduces the viral production, almost 93% reduction we will get. And also, in addition, we can calculate the time for virus elimination. And this figure shows a reduction time for virus elimination. So it means comparing the time for virus elimination with and without drug. And if you use nelfinabine, you can get 5 days time reduction. And for cefalantine, around 4.5 probably. And if you use nelfinabine and cefalantine, you can get a 6 days reduction for viral elimination, time for viral elimination. So this is quite high because these treatments can quickly achieve the viral elimination, and which will probably help inhibit the hospital collapse, for example. And so my take-home message is quite simple. So the single nelfinabine might be effect, and the combination of nelfinabine and cefalantine show a quite potent antiviral effect. And this is my collaborator. Thank you for your listening.
Thanks a lot, Professor Iwami, for the elegant presentation. And actually, I have one question. You used an in vitro infectious model, right? Do you think that having an in vivo model would make a difference? Especially, I know that there is currently some publication about the presence of an in vivo model for infection.
Mm-hmm. Well, but so this viral dynamics is data from from patient. So this is in vivo information. And the pharmacokinetics is also in vivo information because from the clinical data set we can obtain. Only the pharmacodynamics is from in vitro, but it's, as you expect, it's difficult to get the in vivo data on the pharmacodynamics. So this is, I think, the best combination for our simulation.
Thank you.
Welcome.
Yes, Stas, you have ask a question.
Yes, Dr. Mandouh, the Dean of
Yes.
our Faculty of Medicine. Yes, please, Dr.
Yeah.
Mandouh.
To ask about the Japanese protocol for treatment, it still include hydroxychloroquine, or it has been withdrawn like most of the European and American countries?
In the situation in Japan, the hydroxychloroquine is not used in very popularly. Yeah. So yeah, of course, you know, in the worldwide, the hydroxychloroquine is under the clinical trial in some of the country, but in Japan, I don't hear much about hydroxychloroquine.
Thanks a lot, Professor Watashi and Professor Iwami for and hopefully we can proceed for further stages to reach an approval for the medication. Actually, all of us are looking for a hope for COVID-19. Thank you so much, and I think we still have a lot of work to proceed for the clinical trials. Thank you. Thank you. Thanks. Appreciate it.
Thank you very much, Dr. Assas. Now we have Dr. Tariq Salim. Yes, Dr. Tariq, you can take your turn.
Thank you, Dr. Heidi, for the effort to arrange for such elegant meeting, and for all the professors. We invite them from outside and from inside. Dear Professor and colleagues, it's my pleasure to introduce next speaker, Dr. Amr El Foly, Lecturer of Endemic Medicine Department, Faculty of Medicine, Helwan University. Dr. Amr will talk about clinical features, comorbidities, and the laboratory characteristics of patients hospitalized with COVID-19, early report from Egypt. Dr. Amr, you can start, please.
Thank you, Professor Dr. Tariq, for your kind presentation, and thanks for my colleague to inviting me today to participate in this great, eminent scientific event. My task today is to talk about the early report from Egypt about COVID infection. As we know that coronavirus reported in Wuhan, China in December 2019, Western Europe and the United States are epicenter for COVID infection after China has successfully controlled and contaminated the disease. WHO announced COVID virus as a global pandemic in March 2020, and over 200 countries all over the world now had an active reported cases of COVID infection. The timeline in Egypt, the first reported case was recorded on the 14th of February. At the 8th of March, we reported the first case fatality related to COVID infection. There is important definition for controlling and coping with this disease. The first, we need to flatten the curve. And the second thing, we need to raise the healthcare capacity to help to meet the increased demand of medical service. And second important thing, that effect of inadequate mitigation could end up with resurgence, which is the reappearance or re-rise of the COVID infection. All these definitions are well known for every country, but each country had their own policies in the treatment depending on their economical status and the burden of medical problem. The Ministry of Health in Egypt had taken several measures to cope this infection. The first thing, they devoted 34 isolation hospitals assigned for COVID infection for isolation and treatment. These 34 centers are widely distributed all over Egypt in every governorate. The current Egyptian situation, we have a low number of infection compared to the rest of the world. We have almost 28,000 cases reported till yesterday. Our study design included 195 COVID-infected cases, confirmed their diagnosis with real-time PCR for COVID virus RNA via nasopharyngeal or oropharyngeal swabs. This is a cross-sectional study, included both asymptomatic carriers for isolation or symptomatic cases for the treatment. Of course, this was during the early initial patch of infected cases in isolation hospital during the time period between March and early April. And these reported cases was analyzed in a single center devoted for COVID cases by the Ministry of Health under supervision of Helwan University medical staff. The 15th of May hospital. Our aim was to assess the characteristics and the clinical presentation and mode of transmission among the Egyptian population. Our initial analysis among these 195 cases, we found that 13 cases in the pediatric age group, while middle age group between 18 and 50 years are 105 cases and 77 cases among the elder age. Further sub-analysis showed that almost 100% of the pediatric age are asymptomatic for COVID infection, and they are just admitted in the hospital just for isolation during the initial infection. If we look to the middle age and the elder age group, we found that the COVID infection was symptomatic in almost 50% of the middle age, compared to 80% in the elder age. So we tried to do comparative analysis regarding these points about comparing these two groups regarding the mode of transmission, whether from recent history of traveling in contact with foreigners, unknown source, working in medical field, or have positive family contacts, assess the rates of comorbidities like diabetes, hypertension, and cardiovascular disease. What are the types of symptoms associated with COVID infection in Egypt? To assess the stage of COVID severity, whether it's mild, moderate, severe, or critical condition. Compare the results and the mean values of some basic laboratory findings. And finally, to assess the radiological findings among those patients in Egypt. The baseline demography of COVID cases according to their different age group was analyzed, and we found that the male to female ratio in the disparate age group was almost the same, 60 to 40% male to female ratio. Of course, there was no statistical difference between the different age groups. The distribution of the 195 cases, as we see that 7% of the pediatric patients, 7% has a COVID infection, 54% had middle age, while 40% they had elder age group. And these are the mean age in every group, 11 for the pediatric, 35 for the middle age, and 61 for the elder age. The comorbidities, we found that more of them are highly distributed among the elder age groups, at which we have 44% of them were diabetic, 43% were hypertensive, and 20% almost have cardiovascular. Figures are lower in the elder age group. The mode of transmission, I would say the source of transmission. Of course, during this early patch of COVID infection isolate case, we could take a history about these important sources of infection. And we found among the pediatric group, most of them, 60% of them, were significantly affected due to a positive family member with COVID. While in the middle age, we found that 21 of them, they are working, they have a working in the medical field as a health persons, and they mostly acquire their infection from their work. And 10% of the middle age are working in the tourism, and they were in contact with foreigners. While the elder age group, 20% of them had history of recent traveling abroad, while the majority, in 60%, they had unknown mode of transmission. Regarding the clinical presentation, we found that the highest clinical presentation was the cough, dry cough, in 60% among the elder age group, while fever in 46% and 23% in shortness of breath and dyspnea. Of course, this clinical presentation was obviously higher among the elder age compared to the middle age group. They almost half the GIT symptoms was significant, but they might be presented with COVID infection in 11% in elder age group and 6% in the middle age group. If we look for the clinical stage severity, we classify the stage according to the clinical finding into asymptomatic cases. They were represented in 4%, moderate stage in 40% of the whole cohort. Severe cases are classified in 10%, and critical conditions occurs in 5.6%. Going back to the different age group, we will found that the pediatric age group, all of them are asymptomatic, while the middle age group are mostly distributed among the asymptomatic and mild stages. If we look to the elder age, they have a range of presentation between moderate to critical presentation. This bar chart shows this, I'll confirm this finding about the pediatric age group are totally asymptomatic. If we look to the age, they are more presented in the moderate, severe, and critical stages. And of course, this was statistically significant, while the middle age group, they are more presented within the asymptomatic stage. If we go to the CT positive finding or criteria for diagnosis of COVID infection, we found that the positive criteria was presented in 83% among the elder age group, which means there are more than 80% of the elder age group are associated with COVID pneumonia. Compared to the middle age group, only 40% of them had positive CT finding at time of presentation. The bilateral or unilateral presentation was not significant. Most of them were bilateral in 80% in both cohorts, and 20% has a unilateral presentation. If we look to the laboratory results, the tremendous action of the neutrophil to lymphocytic ratio, we found that the mean value among the different age group are getting higher according to the patient's age, which was highly significant among the elder age group. Not only, but also this arrow bar chart shows that the neutrophil to lymphocytic ratio correlates directly with the severity of infection, not only the age, but also the severity of infection. Of course, both of them are in parallel, but this is how the neutrophil to lymphocytic ratio reacts. Now, we want to analyze the clinical presentation of asymptomatic versus symptomatic COVID patients. As we know that the COVID infection affects the upper respiratory tract or the lower, plus or minus the lower respiratory tract infection. And we have asymptomatic COVID carrier cases or symptomatic COVID infection. In the asymptomatic carrier cases, of course, they have no symptoms, but sometimes their radiological findings could be positive for lower respiratory tract COVID pneumonia. Among those asymptomatic cohorts, 73 cases distributed according to the middle or elder age, we found that 10% of the middle age had positive finding of CT in the CT, compared to 23% among the elder age. Both of them are asymptomatic. The laboratory finding with the CRP level or the neutrophil to lymphocytic ratio were not significant between both of them, and they are not elevated, which reflects the clinical status of the patient. Going to the other arm, for the symptomatic COVID infection, some patients had upper respiratory symptoms of COVID infection, and others had lower respiratory tract COVID pneumonia. Among this symptomatic cohort, we have 109 cases. We found that the CT was positive in 93% of the elder age group, which means the elder patients not only lean for severe cases, but they also more lean for lower or COVID pneumonia, compared to 70% in the middle age group. While 30% in the middle age group, they had upper respiratory tract COVID infection. Again, there is no statistical significant difference about the unilateral or the bilateral presentation. The CRP and the neutrophil to lymphocytic ratio acts directly with this presentation, at which the CRP was significantly higher among the elder age group in 83%, and the mean value of the neutrophil to lymphocytic ratio was elevated again in the elder age group. So in conclusion, for the initial report from Egypt, most of pediatric COVID cases are asymptomatic. The elder COVID cases are leaner for symptomatic, more symptomatic presentation. They have more lean to, they are more lean for COVID pneumonia and for more severe stages of presentation ranging from moderate to critical stages. CRP, neutrophil to lymphocytic ratio, and CT chest are effective integrated tools for rapid clinical assessment of disease severity. The current incidence of COVID cases could be explained by a young Egyptian population who are presented as asymptomatic carriers, or they might have a mild form of COVID infection, especially that Egypt tracing protocol against COVID infection. This is the international map, the mean age, the median age group in each continent worldwide. And here we could see that Europe had the highest median age group compared to the rest of the world. Japanese population has significant older median age group compared to the rest of Asia. The United States, they have a median age group of 38. Africa had the youngest median age group. Of course, the high median age group would reflect the good medical service for these countries. Egypt, they have 85% of the Egyptian population are below the age of 50 years. If we look to this model, of course, between the initial stage of COVID infection and the terminal stage of disease control, we have different colors representing the case mortality in red, the recovered cases in blue, and the active cases in orange. Of course, during time, dynamic timeline of COVID infection, the number of infected cases is decreased by time, and the number of recovered cases will increase until hopefully we reach the terminal age of COVID control. This dynamic timeline could be variable, prolonged or short, according to the measure taken by each country. If we look to Egypt, Egypt has a median age group of 24 years. We have a total number of around 24,000 cases. The mortality rates is 3.9%. 24% of the Egyptian population had a disease recovered from COVID infection, and 72% they have still active COVID cases. If we compare this with other European countries, Germany, Italy, Spain, France, and United Kingdom, their median age group range between 47 Germany and 40 years in United Kingdom. We see here that the case fatality are ranging between 2 to 15% among these European countries, except for Germany. They have a lower rate compared to the rest of the European country, which might reflect the effective medical healthcare service provided for those risky age group. Not only, but also, Germany succeeded to have a rapid time in recovery, number of recovered cases compared to the rest of European countries. They have almost 90% of their infected cases had recovered from COVID infection. Going to Asian countries, we found here that in South Korea and Japan, they have a median age group more than 40 years, while China, they had a median age group of 38. The mortality rates here, or case fatality rates, are very low, 5.3 in Japan and 2.4 in South Korea and 5.6 in China. And all the Chinese, most of the Asian countries succeeded to reach more than 90% of recovered cases of COVID infection and disease control. Also, what is important here that the figures of the infected cases among the Asian countries are lower when compared to Europe and the United States. The current situation in the United States, they had a median age of 38 years. The total number of cases was dramatically high, 1,800,000 cases, and the case fatality is 5.8, and they have still active viral infection in more than 65%, and 30% recovered from viral infection. So the conclusion is elder age group have higher risk for mortality. Asian countries had rapid disease control and lower number of cases compared to the rest of the world due to their previous experience from SARS in 2003 and 2012. The high median age countries have a good medical service quality, but they are more lean for higher mortality rates, such as in Italy, Spain, United Kingdom, and France. Japan, South Korea, and Germany had the least case fatality despite of their high median age group. At the end, I want to acknowledge this work to Endemic Medicine Department, who participated in the treatment of patients. And this work has been submitted for publication in the Journal of Infectious Disease in Developing Country. Finally, thanks for your attention.
Thank you, Dr. Ram, for your very good, very it's difficult, it's easy, although it's great work. Thank you very much, and your presentation also is very nice.
Thank you.
Thank you very much. This is not strange for the endemic department in our faculty. You are all excellent. Next speaker will be Dr. Dalia Gaber, Lecturer of Biochemistry, Faculty of Medicine, Helwan University. You're welcome. Her speech will be about online team-based learning sessions as interactive methodologies during the pandemic at Helwan University. Dr. Dalia, you can start, please.
Good afternoon, everyone. It's a pleasure to be part of this very eminent meeting. Just a second, I'm going to start my slideshow. So I'm going to talk today about the effect of the pandemic on medical education, and I'm going to stress on our reaction as Faculty of Medicine, Helwan University, especially that we did some online integrated interactive lectures for our students, and I'm going to focus on the online team-based learning sessions. As we all know that on the 11th of March 2020, the COVID-19 was declared as a pandemic by the WHO, and since then it has been spreading across the globe. Since then, we have been passing through a state of turbulence. Of course, this had a great impact on medical education. Currently, the whole educational process is really facing a big challenge. So about the threats we were faced with, that we found ourselves being enforced by physical distancing, and we had to shift medical education towards virtual learning. As medical educators, we had to utilize every possible digital tool in order to support the educational process. An additional big challenge is the large number of students joining our faculty. But still, it's our responsibility as faculty members to keep them on track despite the current situation. What was the action taken? In our faculty, we decided to work immediately to maintain our educational strategies despite the sudden lockdown. So we used the Zoom application. It was a very easy one, and it was possible to deliver online lectures following a pre-scheduled timetable. Still, we want to continue our interactive TBL sessions, which we used to deliver inside the ordinary classroom. Thus, we decided to implement online TBL sessions. So through these TBL sessions, we can encourage our students' engagement, we can stay close, we can motivate our students, they can still be on track, and we hope that we will not lose our students, and really it had a marvelous effect. So briefly, what's team-based learning? It's an interactive teaching methodology. It's characterized by being learner-centered and instructor-directed, which means it's a student-centered methodology through which the students prepare the lecture, they interact with each other in the class, they answer questions on their own and in team, and they discuss these questions with the tutor, and it's a very good way to assess our students through a formative assessment interactive methodology. So what are the benefits of such interactive teaching classes like TBL? Usually, interaction in medical education induces more passion for learning. It tackles the higher level of thinking, promotes integration. Through TBL sessions, students can solve problems, they can self-learn, they think, they discuss, they express their ideas together, they acquire teamwork skills. It switches learning from being teacher-centered to student-centered, and it brings benefit to students at all levels. So briefly the structure of a TBL session, how does it go? We provide the students with reading material almost 1 week or 10 days before the session. During the session, the students are allowed to solve 10 to 20 multiple choice questions. First, they answer the questions on their own through the Individual Readiness Assurance Test, or the IRAT. Then they answer the questions together, the same questions, while they work in teams. This is called the Team Readiness Assurance Test. And this is followed by immediate feedback from the instructor. The instructor may clarify some obscure points. Then the final stage is that we wrap with a problem solving, which obeys 4S rule. It has specific criteria. It must be significant, same, specific, simultaneous. So that was a brief discussion of how a TBL session is run. The problem was that now we are distant from our students. What shall we do? How can we run these interactive lectures? So we had in year 1 students, for example, we have 900 students. So in order to run such session, we had to divide our students into 9 groups. And really, I must thank here my students for being so cooperative. They divided themselves into groups, into 9 groups. And we had 9 Zoom meetings on the same day. During each meeting, each group was divided into 4 teams. So we had a total of 36 teams, almost 36 teams. Before the session, of course, we interacted together with the team leader. Each team chose their team leader, and we interacted together in order to prepare for the session and to rehearse for the session to do it well. Then, when the session started, we needed a very great feature of Zoom, which is the breakout room. With this feature, I navigate to distribute the students and to divide them into, like when we can divide ourselves now into separate rooms. So that each team interacts separately inside the room without any disturbance, and they work in private. They can do their IRAT, their TRAT completely in a good environment, interacting together, communicating together very well. Then we can open all these rooms and get back together and continue our session. So this room was So I wanted to measure the student feedback because this is very important. After we do any new tool, we have to measure our student feedback, whether they are satisfied or not from this session. So a survey was disseminated among the participants to measure their satisfaction, and almost 85% of them expressed their satisfaction with the session. Of course, there were some problems like network problems, but overall we can say that it was satisfactory. So our first online TBL session was held on 25th of March for first-year medical students with the participation of 820 students. Of course, other online TBL sessions followed for second-year students with participation of 450 out of 500 students. This work has been published in the MedEd really good stuff in collaboration with my dear colleagues, Professor Dr. Mohammed Hani and Dr. Heba Amin. What about the other online distant learning modalities we used at the Faculty of Medicine, Helwan University? Of course, my colleagues, the faculty staff members, all of them, they exerted a tremendous effort, and they did their best really during this sudden lockdown, and they performed integrated lectures between different departments. The PBL sessions, they didn't stop. The PBL sessions, they continued since the lockdown. Seminars were prepared by the students and supervised by staff members from different departments. Frequent assignments were given to the students, and they were provided with the needed feedback. Office hours were held regularly almost each week, as far as I can remember, for the biochemistry department at least, and for other departments for sure. I would like to thank very much my students for performing wonderful seminars. These 3 seminars were prepared and presented by year 3 and year 1 medical students for the biochemistry department, and my colleagues attended, the staff members attended these events, and they were really marvelous. I would like to thank my students for being so active, enthusiastic, participating, and interested, really interested in learning, and I would like that, I hope that they will continue this way. So what was the outcome from this experience? That with the tremendous efforts and unbeatable enthusiasm of our faculty members, we were able to complete 2 consecutive online modules for our medical students at Helwan University. A special thank you goes to our faculty leader, Professor Dr. Mamdouh Mahdi, for the continuous encouragement and support. And I would like to end with this saying, which I like so much: what comes from the heart goes to the heart. And thank you very much for listening to my presentation. Thank you.
Thank you, my dear colleague, Dr. Dalia. Thank you for your efforts. And now we will move very fast to our last session, Dr. Heba Amin. Dr. Heba Amin belongs to the Pathology Department, Faculty of Medicine, Helwan University, and she is a female fellow 2020. Thank you very much, Dalia, and Dr. Heba, you can start.
Hello, everyone. I'd like to express my appreciation for the organizing committee for allowing this participation to present our online experience in the Faculty of Medicine, Helwan University. Our presented topic is about learning management system versus portfolio of tools during the pandemic, which is a post-COVID adaptation study under the supervision of Professor Mamdouh Mahdi, revised by Professor Mohammed Hani, and presented by me, Heba Ami. First of all, to clarify this apparently integumentous title, our meeting agenda includes an introduction of what is e-learning, why is it needed in today's education, what's our plan for the crisis, what was our application, learning management system versus portfolio of tools during the pandemic. We used the EKB learning management system QBank. Besides portfolio of tools, including Google website, YouTube channel, online assignments using Google Forms, game quizzes, Incision Academy, Zoom meetings, Skill Jam, virtual patients presented by the AKB, and online surveys. We will present also how to overcome challenges of implementing the e-learning, and finally a take-home message. What's e-learning? It's the learning conducted by electronic media, typically on the internet, to access educational curriculum outside of a traditional classroom. In most cases, it refers to a course program or a degree delivered completely online. So what we need the e-learning in today's practice? There are mainly 5 advantages of the e-learning. First of all, it brings what learners really want: faster delivery, lower cost, more effective learning, and lower environmental impact. So what was our practice in the pre-endemic era? In the pre-endemic era in Egypt, there was a concern towards the implementation of a unified national learning management system provided by the AKB, which is freely offered with many useful resources, features besides the QBank. For any learning management system, there should be a working official email for every student. This is a preview for our learning management system, Helwan domain. However, we find that our students used to have non-official Google websites as a repository for their studying material. They were created by their students' coordinators for easier accessibility. So in the pandemic era, we planned for the crisis. The sudden unpredicted national lockdown has greatly changed our administrative vision towards the security and accessibility issues. The e-learning committee decided to implement a portfolio of technology-enhanced learning tools. Owing to their accessibility, the committee uses the students' Google websites as official emails, as official websites, as they are easily accessible by all the students. They don't need to have an official email to gain accessibility. These are the students' websites. The students also have created a YouTube channel for the Faculty of Medicine and uploaded their educational material. Moreover, the medical education staff members have created and recorded a YouTube lectures that have informative educational ideas on enhanced technology-enhanced learning tools, and these lectures were uploaded to our YouTube channel of the Faculty of Medicine, Helwan University, as well as the SU Menafry channel. Amazingly, our students also have their active contributions in these educational videos. They created videos to show other apps that can be used for the online platform. Other portfolio of tools that were used by our faculty is the Zoom for the PBL, TBL sessions, lectures and seminars, and the office hours. Google Forms were used for assignments and logbooks. The anatomy and surgery departments used Incision Academy for the assignments. Some of our staff members preferred to use Camtasia Studio for creating their educational video. Game quizzes were used. Virtual patients with skill gem provided by the AKB were also used, besides the monkey surveys for the feedback. In our portfolio of tools, we used the AKB learning management system, but we use only the QBank. It's QBank, the secured AKB learning management system QBank is made available for all the students for self-learning and running competitions. However, we have only 85% of our students having their active official emails. This available student QBank encouraged other students to activate their official emails. I'd like to navigate through the students' websites. This is the Google website of the students. It has an intuitive, easy, friendly user interface where any student can have access by only having the link without an official email. Here are the lectures, the labs, the EKB link, and also the e-library with the books and references of that they will need. Their skills lab can be accessed here. Their PBL cases are uploaded, and also the contact with their students coordinators that are in contact with the staff coordinators. The students can have an icon that can access into the AKB directly. But here, this part of the website needs authorization by the official email. So this link will open directly into the AKB, but I need to sign in with my official account to get in. Worth mentioning that this QBank is created by the students themselves. They have authored the cases and reviewed the cases under close supervision and mentorship of the staff members. This was made by the students as a summer activity, and it served us in the pandemic to provide the students with precious material that can help them through the pandemic for the distant learning. Also, we have here, going to the home, we can access to the online lectures, where from the Google website, the students can reach their lectures on the Faculty of Medicine Helwan University YouTube channel. This is the YouTube channel into to be embedded into the website. The students are creating playlists for every module, and this playlist for e-learning contains the educational videos. This is the one. This is the one created by Dr. Dalia, for example. This is one created by a second-year student. A second-year student showed us how to use the OBS for video making of the lectures. Here, the virtual patients
presentation
were used as an educational material.
Have you ever experienced any dysuria, hematuria, or pyorrhea?
Not that I'm aware of.
Going back to our websites, here we have a website with intuitive interface that is accessible for all the students, where all the educational material are uploaded, and it's linked to their YouTube channel and also to the EKB. Going back to our presentation, here in our presentation, we would like to recommend having a checklist to evaluate in an objective way the efficiency of the used platform for the online education for our students. This is the proposed checklist. We have in our portfolio of tools, or our created e-learning management system, intuitive user interface. We have accessibility, we have customization and personalization. These three features are Google websites. We have a flexible reporting and analytics through the EKB Bank. We have a Q Bank from the EKB. We have assessment tools from the EKB. These 4, 5, and 6 are provided by the EKB learning management system. We use the Zoom conferencing for software, which was Zoom. We had a feedback system through the Google Forms and the monkey survey. We have no discussion platform or wiki, and the security is somewhat not present except for the Q Bank. So here, if we would like to compare using only the EKB learning management system, we would have 5 out of 10. But when we use the EKB Q Bank plus the Google website, plus the Zoom conferencing, plus the Google Forms, plus the monkey survey, plus the other applications as the Skill Jam and others, we got a score of 8 of 10. This was a joke presented by our students that this was more efficient than costly learning management systems provided by other universities. It's worth mentioning that it is costless, completely costless. So we would like to go how to overcome the challenges at the institutional levels. We would like to appreciate the staff members and the students that were engaged in this present achievements. Secure free institutional internet connections, provide servers for hands-on technical support, and continuous communication and response. At the level of the staff members, we'd like them to have the e-learning course as engaging and inspiring as possible, but simple and meaningful, and to respond to the feedback. Finally, we believe that our brilliant students are our partners, and their active contribution is the cornerstone for our faculty development. I'd like to appreciate them all. We have our online team that created the YouTube channel and the Google websites and uploaded regularly the edited video lectures and other educational materials with and I'd like also to appreciate the Q-Bank creators, the authors, and the reviewers team. Our take-home message is that using a checklist is required to evaluate the used platform in our faculty. During the present state, we think that accessibility is prioritized over security. except for the content with copyright issues, like the QBank, which should be secured. The educational material should be made available with no restrictions in this pandemic era. It's surely done after the approval of the staff members, and we recommend that these are our educational material with other students' engagement is a cornerstone for any successful procedures. We have our attempt to provide the conditions in which our students can learn. Thank you for your attendance. Thank you for the organizing committee.
Thank you very much, Dr. Heba. It was our pleasure to have you with us today. And now we are finally with Dr. Mamdouh for the final question discussions and for the closing remark. Yes, Dr. Mamdouh.
Some questions, search for him at the end of the session. Welcome, Dr. Alfishawy. I wanted to ask you about two questions, rapid questions. What
Yes.
Of the medical staff or professional working, is it a real benefit from the much vitamins applied to the patient with high susceptibility?
Yes. So regarding, you have two questions regarding hydroxychloroquine prophylaxis and regarding vitamins. So number one, regarding hydroxychloroquine, although the study was published last night from the New England Journal of Medicine done in Minnesota, they said it didn't help. But they used it whenever you already contacted a patient, like as a post-exposure, not as a as like what the Ministry of Health is doing here. And it failed. It wasn't successful to protect the healthcare workers. That's number one. Although the Indians just announced like a few hours ago that they said that hydroxychloroquine with appropriate PPE already protected, but it's not, it's just like some news. So till now, I don't have any data to recommend hydroxychloroquine for prophylaxis. It may be helpful, but till now, only one study said no. Regarding the vitamins, most of my patients will ask, like, doctor, like I heard that this vitamin can benefit. There was no like a randomized full trial about a vitamin, but whenever a patient comes and say, I need to take this vitamin, I say, okay, fine, take it. But some authors were concerned about the problem with vitamin C and hydroxychloroquine, because hydroxychloroquine works by increasing the pH of the lysosome. And then ascorbic acid decreases the pH. So I don't know if this interaction will affect. Maybe it will be beneficial, maybe it will be harmful, I don't know. So the answer is I don't know, but whenever a patient insists, I tell him, okay, it's fine, you can take it. The real deal is the hydroxychloroquine and the Egypt thing that I mentioned in the lecture. The hydroxychloroquine, when it was used, they said that it's the most benefit when it was done in systemic lupus patient was in patients who are hypersecretory for TNF. And when the study that was done in 2018, I mentioned it was done in Egyptian patients, and they found that Egyptian patients are like genotypically hypersecretory of this TNF alpha. So maybe that we are genetically different. Maybe that's why it's causing benefit in moderate cases. So that's why I think it has to be tested. So we need a randomized controlled trial for hydroxychloroquine for moderate patients or severe or mild, whatever, and then we will see the effect. Then we will know exactly if this is fine or not.
Thank you so much, Dr. Mostafa, for your elegant presentation. Now we are going to end our session. It was a very successful one. First of all, I would like to express thanks and welcoming to Professor Dr. Khalid Abdel Ghaffar for his active participation, encouraging us in our session. His participation was very. Secondly, I want to ask to all of us to thank Professor Dr. Maged Negma for his support to Faculty of Medicine and the medical group of Helwan University. Also, Professor Dr. Ramona, the Vice President for the Postgraduate and Research, for her great effort to support to hold such a very important first international virtual conference regarding the COVID-19. Really, I would like to thank all the speakers. All of them are excellent. Their presentation were really precise, informative, and to the point. With this is the scientific way to present scientific or I will comments on our session today. Our first speaker, Dr. Mostafa, that COVID-19 is a global health problem, which is the greatest challenge in the whole world after the World War II. It is more than health problem as it affects all the aspects of the life. And fortunately, Egypt had very promising research regarding the COVID-19. The second presentation, Dr. Dietrich from Martin Luther University Hospital in Halle, Germany. In the radiological CT, we can find that the CT is a very crucial in diagnosis and follow-up of COVID-19. There is a recommendation to use it as a routine for diagnosis. Using the CT in diagnosis is not only for the patient management, but also for pandemic management. Our colleague, Dr. Amr El Foly, his presentation was excellent, very informative, sharp, clear, and I'm proud that we have somebody like the team of the endemic department, like Dr. Al-Qassas and his team. Dr. Amr El Foly discussed the clinical and diagnostic feature of COVID-19 with different age groups among the Egyptian patients, and he discussed the study for the patient in hospital 15th of May, which we are working there, our team, in the intensive care and the pulmonology and internal medicine and endemic disease. We'll go to the Japanese presentations that's giving a hope for new antiviral like Nifenavir and Cefarantine, the new antiviral drugs, which has a very promising result in Japan and will be introduced the project with the Faculty of Medicine, Helwan University, and this was something very good. And thanks to the effort by Dr. Qassas to fulfill such agreement and to start to have this experimental drug on our patients. Second Japanese presentation talk about the mathematical modeling and its importance in the prediction of future of the pandemic. It was very nice also. Now we are coming to our pillars in the medical education in our School of Medicine, Helwan University, new era of electronic or online learning. The first presentation was by Dr. Dalia Gaber regarding active TPL was successfully held in the Faculty of Medicine, Helwan University during the quarantine. Now, in the Supreme Council of University and the Ministry of Higher Education and Scientific Research will recommend next year will be depending upon such methodology of learning by not less than 80 to 90%. Staff and the students very effective. Finally, Dr. Heba discussed the learning management system together with other tools had a crucial role in the learning system at the Faculty of Medicine, Helwan University, and she's pioneer in the AKB maneuver for the learning management system. Really, I would like to thank both of them for their efforts and the excellent dedication for the sake of the School of Medicine and the thank you very much. At the end of the session, I would like to thank all the participants, all the audience, and I will all of you know that all questions applied at this session will be replied after the session will end because we ran out of time by more than 1 hour. Thank you for everybody and till the next meeting, inshallah. Thank you very much.